is Christine Lum Lung. The company is Origin Healthcare. Christine?
All right. Everybody see my slides?
Yep.
Okay. Thank you all for having me. We are Origin Healthcare, and we are redesigning hospital level care. We're an expert medical team, and we're bringing hospital care to patients so that they can stay in the safety and the comfort of their own home. So I'm Christine Lum Lung. I'm the CEO of the company. I am a board certified physician who's practiced hospital medicine for over 20 years in the hospital. I also was the founder of an independent, successful hospitalist company, and deployed hospital medicine was fairly new, so I'm familiar with innovative care models. Our Chief Quality Officer is Dr. Amy Espinosa, who is also a board certified hospital physician. She has also practiced for over a decade and most recently spent the last 5 years with Grand Rounds Health. And she was their interim director of quality and safety during the first 15 months of the pandemic. And during that time, helped them develop and roll out a telehealth program. And finally, last but not least, Jory Anderson is our Chief Nursing Officer. She has expertise in critical care medicine. She worked in the cardiothoracic ICU at UCLA, so caring for some of the sickest patients in the hospital. She also has experience in performance improvement, education, and her public health nurse certification. And this is a very unique audience because I don't have to tell you that the reason that we're here is that we know that what's happening right now is not working for hospitals and patients as far as the inpatient care perspective. We see in every healthcare conference we go to that curve where healthcare costs continue to escalate. We saw it earlier today. And unfortunately, we know that in spite of our best efforts, that bad things happen when patients go into the hospital. Patients get confused, they get delirium. We know that there are patients for various reasons that don't want to come and get their care in the hospital facility, and hospitals also bear the burden. Even prior to COVID, they had difficulty managing bed capacity, and clearly, as we all know, those problems just got worse with the pandemic. And so this was an experience that we all had as clinicians, but then Amy unfortunately has a personal experience as well. Her mother-in-law was admitted for a routine hospital admission, unfortunately developed complications that were a direct result of that stay and ended up passing away. And so it was really important for us to develop a solution that solved these problems. We've designed a model of care that provides safer care, higher quality, and for significantly lower costs of care. And hospital at home is very different than any care that's currently being provided at the home. It's not hospice care, it's not home health care, it's not personal health aides. This, for all intents and purposes, if you were this sick, you would be in the physical walls of the hospital, but now we're giving you an option to receive that care at home. So once we get a call from a clinician that they have a patient eligible for hospital at home, we'll deploy our medical team to the home. And we have a full suite of diagnostic tests, so radiology studies, laboratory studies that we can perform in the home. We also have available many of the same medications, IV fluids, IV antibiotics, respiratory therapy. We're connecting patients through remote patient monitoring, which I'm sure everyone is familiar with, and the talk that we just heard as well too. So this is our connectivity that allows us to monitor vital signs for the patients. The tablet is our communication device. We can set a customized schedule for the patient as well. We have clinicians that are on call 24/7. Our team will physically deploy to the home at least once a day, twice or more, depending on the care needs. And we have a physician who also does separate telemedicine visits. And we know it's really important when we're doing this, so we integrate the patient's family. And so they're available to join any of the calls, either remotely or obviously in person. And we're actively bringing all that information that we're finding out about the patient in the home back to their primary team. And this is just a really quick snapshot. We are able to monitor full sets of vital signs, activity, sleep, and again, an example of a customized schedule for the patient. A really important part of what we're doing is we want to go beyond just treating that acute episode of illness for the patient. We're very committed to eliminating the gaps that exist in health and cause health disparities. And so we're doing this in a couple of ways. We're actually bringing hospital level care to patients who currently have difficulty getting that care, whether for social or economic reasons. And by providing hospital care in the home, we're actually changing the existing power dynamic that might be a barrier for some patients to get care in the first place. So instead of mandating that patients come into our hospital facility, we're now empowering patients to have a choice so they can actually choose to invite us into their home. And we know that that trust that they're extending us is very significant. And we're making sure that our staff has the skills and trainings to work in that unique environment and to really honor the unique needs of each of our patients. In the home, we're able to screen for social determinants of health and see all those other factors that are impacting patients' health and wellness. and we're making referrals to community resources to help fill those gaps in need. And we know the importance, obviously, of mental health as far as how it impacts wellness. And the anxiety and depression scores were much better when patients received their care at home. And one of our first hires to our team is an expert in behavioral health. And the great thing about this is the results are proven. This has been used around the world for decades in countries like Australia, Italy, and Spain. And here in the United States, big thank you to institutions like Mount Sinai, the Brigham, and Hopkins. Some of this data is from their experience as well. There's perfect alignment of patient experience, quality, and cost, which we know is incredibly rare in healthcare to see. And impactful for us was the order of magnitude that you're seeing of these improvements. And going back to the cost, a significant cost savings per admission for our Medicare and our commercial payers. And clearly we know that care is moving to the home. There have been technology advances, the rapid adoption of telehealth. As was mentioned earlier, there are regulatory loosening of barriers with Medicare now permitting during the pandemic a waiver for hospital care at home. So we truly feel like this is the future of medicine. And what we're doing, we feel, is very unique to what's happening out there. We know that there's a lot of activity in the healthcare space right now, a lot of technology advances, and we know the importance of technology, but there's also the importance of personal connections. There's this last mile of care. So you can have all the technology available, but our patients are experiencing an unplanned and an acute episode of illness. And so they need that expert medical team physically present to assess and to begin immediate treatment. And most of these other solutions don't offer that possibility for patients. The market opportunity is large and nascent. While not every patient can, nor should they receive their hospital care at home, it's estimated that a little over 5 million of the patients that are currently in hospital would be eligible. So a significant market opportunity. And we know that number will just continue to grow. Our baby boomers are aging. And so by the year 2030, we'll see an increase in the number of patients over 65 by 30%. And those patients are increasingly saying that they want to receive their health care at home. There are multiple stakeholders involved, and two that are very important that are not on this slide, obviously, are the patient and family and the providers. So we know that they're important to gauge. This is our business model, which is a B2B2C model. We are currently in active conversations with all of these different stakeholders. We're working on a pilot with a commercial payer. We're finalizing contract with our first self-funded employer. We have an RFP out to a large academic hospital system and talking with those models of care, ACOs and others. You have a team of experts that have deep industry experience in healthcare, business, entrepreneurship. I'm pivoting a little bit away from a traditional pitch because I want to take advantage of this incredibly unique platform we have with people that understand that healthcare didn't get broken overnight, that there are many reasons that healthcare has been slow to adopt change. I'm incredibly motivated and excited by the speakers that I've heard all day today and that are upcoming as well too. So my ask really is that we as clinicians and people committed to putting patients at the center of care really try to move and push those entrenched players to adopt change in a way that really serves our patients better. We are, I'm happy at any point to talk to anyone about the traditional pitch metrics as well too. We are starting to fundraise. We have started seeing patients, and in that vein, I'll tell you about our patient that we saw who was our first patient. Tammy has multiple chronic medical problems, where there's high level of oxygen at home, and she was having weight gain and worsening of her breathing, and her pulmonary doc felt that she must be admitted to the hospital. But Tammy has an adult son at home who has mental health issues, and she did not feel she could leave him unsupervised at home. And so she declined admission to the hospital. We were able to go to her home, assess her. We started on IV medications, monitored her. And over the course of the 3 days caring for her, we spent a couple of hours in the home each day. We performed safety assessments and plugged some gaps that she had. We took her food out of her cabinet and taught her how it was contributing to her heart failure. We made sure that she had the mental health resources to help support she and her son. At the end of the stay, not only did we save money from the traditional hospitalization, but we did it in a way that kept Tammy and her son safe. And we know that there are so many more patients out there who are struggling with very tough decisions about their own health and other consequences, and we want to be able to fill that need for them. So thank you very much. I'm happy to answer any questions.
Thank you. Thank you, Christine. Judges?
I get the essence of this, and I think it's, you know, it's got a lot of merit. I am going to ask about the business model, though. How scalable will it be to deploy, service workers, docs, you name it, going from place to place, like as we used to? How can you scale this?
Yes.
And how are you going to get reimbursed for certain visits and so on and so forth? Yeah.
I'll answer the last part first and then back up. So the business model, the conversations we're having with the payer. So anyone that would normally pay a hospital would now pay us for those services. And because the studies will show about a 30 to 40% cost savings, what we've been talking about is a percent discount off of what's called a diagnostic related group. So it's the code for heart failure gets paid so much. Because we would be able to provide those services for less, we would be getting a discount off of that to provide that level of care. And as we've demonstrated in the patients we've seen, we're able to significantly lower the cost of care from a traditional stay. For commercial payers, they're very excited about this. So an average commercial payer pays 189% of Medicare for their same exact patient. I'm in Northern Colorado. The rate up here is 330% of Medicare rates. So there are places in the nation where there's a significant cost to the commercial payer, Medicare Advantage, even a Medicare patient as well too. So we know that they're interested in paying our self-funded employers who are managing really tight budgets, and obviously the difference between paying a significant amount and healthcare costs for their employees could make or break their business as well. So we've been getting a lot of interest from the self-funded employers as far as how to manage their plan. The scalability of this, absolutely, there's the issue. I would say we have two things. One, we can provide the platform, so the policies, the procedures, the regulatory issues, but we also feel like there will be places that won't be able to do this because they don't know how to manage the workforce as well too. We are already getting very good interest from people who want to work with us because, as we know, unfortunately, the hospital has burned out a lot of clinicians at this point, and we're providing a more meaningful interaction with patients. You're not seeing the revolving door because you're actually able to impact their lives in a way that will have downstream impact for them. The ratio of time that you're seeing is much smaller than you would expect in the hospital as well too. And then we're leveraging technology. We have some technology from the remote monitoring. So our physicians are doing the telemedicine visits. And we're also starting to do some early brainstorming with some IT experts about some other things that we've learned through practicing that we actually think will significantly allow us to improve our efficiency and our scale. So we want to provide the optionality, and we're an independent group. There are hospital systems, especially with the waiver, that are developing in this, but the hospital system just keeps that learning in their hospital. We want to be able to learn and be able to scale it to other places in the nation as well too, because hospitals are super busy right now. We want to sort of create an 80% model that's 80% baked, and we can bring the last in and help customize it 20% to the community.
I think a single slide describing the business model will help. You want to add that regardless into a pitch. All right.
Correct.
Thank you.
Any other questions from the judges? Yeah, go ahead.
Rod, curious about, do you have any sort of goals or sort of metrics around what is the maximum number of times somebody will be at somebody's home if something goes wrong? Is there a model around it? How you're staffing for it? Could you speak to that?
We have a quality dashboard of about
Christine, you can stop sharing the slide.
I'm sorry.
So that we can see you talk. Okay.
We have a dashboard about 20 different quality metrics, and we're actively working. There's a hospital at home users group that's pretty active trying to really develop this model. So we're working with them as well too on what are the appropriate benchmarks as far as that goes. Some of it, to be honest with you, depends on the clinical diagnosis of the patient. So if they need twice a day antibiotics, then we will mandatorily be in the home twice a day as well. And so we're also looking at risk scoring patients as far as their clinical stability. Again, we can monitor. Our tech allows us to video in at the drop of a hat to a patient that's having any issues as well too. And so again, we're trying to leverage technology and put into place meaningful metrics in order to risk stratify when a patient should be seen, which team members require or which team members should be deployed to the home as well too. So we're actually collecting all of that data right now to actually help with that.
Yeah, I was more, sort of interested in like an acute event, how quickly you can get to somebody, more on those lines.
Yeah, definitely 911 is still available for any emergency call, but we have our team within 30 minutes to an hour at the most, depending again on their acuity. So where we accept patients and their clinical stability will depend on how far it's sort of a radius, like a gobstopper, how far out you can get your team to them.
Okay. We have one question from the audience here in Santa Clara.
And I appreciate your focus on health equity. Are you currently contracted with any Medicaid health plans?
I'm not, but I would love an introduction to a Medicaid health plan. The payer that we're talking about, we had initially talked about doing commercial MA and then roll into Medicaid. So sort of doing a rolling, but we'd be very interested in doing that. And again, I think, rural communities, there are challenges for that, but there's definitely needs for that as well too. We really want this model to be accessible to anyone who's struggling getting quality hospital care.
Thank you.
Thank you all.
Thank you for the presentation.